In today's video at Medical Sciences by Naftali Humza, we are going to take you through antihypertensives, and the specific class we are going to look at is diuretics. And among the diuretics, we are going to see that their common mode of action is by increasing the excretion of sodium, meaning they are derived from the word diuresis, because sodium increases the loss of urine. It increases urination. So we are going to see that majority of the diuretics act by increasing urination due to loss of sodium, chloride, and other electrolytes. And one of the classes, there are three classes which include, number one, they include loop diuretics. Then number two, we shall look at the Thiazides and potassium-sparing diuretics. So these are the three classes we are going to discuss with you in this session, whereby we are going to talk about the examples of the drugs used there, the mechanism of action, their indication, and adverse reactions. That is what we are going to discuss with you. And as we are beginning, we urge you to subscribe if it is your first time. Go to the like button, like the video, then share to many others. So we are looking at the loop diuretics. These loop diuretics, they act in the loop of Henry as their name suggests. So their action is in the thick ascending limb of the loop of Henry. And examples include furosemide, torsemide, and bumetanide. So furosemide, torsemide, and bumetanide are the examples. So those ones which end with the suffix IDE. They end with the suffix IDE. These are loop diuretics. And these loop diuretics, they have wrong duration of action. They have wrong duration of. So as we move on, we are going to see that we can use them in the treatment of chronic hypertension and hypertensive emergency. And their mechanism of action, these drugs, their mechanism of action is that they act by blocking or inhibiting. They block sodium stroke potassium stroke 2 chloride co-transport. And this co-transporter is found in the thick ascending limb of loop of Henry. So we're going to see in the thick ascending limb of loop of Henry, we find this transporter known as sodium stroke potassium stroke 2 chloride co-transport. That what happens if there is sodium in the rumen, because this is the rumen, this is the basolateral side, and these are the blood capillaries. So we're going to see presence of sodium, presence of potassium, presence of 2 chloride. In the presence of these loop diuretics such as furosemide, this transporter is responsible for transporting sodium from the rumen to the blood capillary. Then we see also transportation of potassium still to the blood, and we also see transportation of 2 chloride ions to the blood. So this transporter enables their reabsorption back to blood. And when sodium is reabsorbed, more water is reabsorbed. But what happened? After losing the 2 chloride ions under the transmembrane part, we see magnesium and calcium enter to equalize the charge. So we see entry of magnesium and calcium. So what the loop diuretics do, their mechanism of action is they act by blocking or they inhibit the transport. So they come and block the action of this transporter. And when it is blocked, it means we can no longer reabsorb sodium, we can no longer reabsorb chloride, and we can no longer reabsorb potassium. And these ions, they continue into urine via the DCT, into the collecting duct, and we lose them in urine. So we shall find the urine we are losing, it contains much of sodium, chloride, and potassium. And remember, still we are exchanging. When we stop potassium from going inside and sodium, we force magnesium to come in. And sometimes we can easily lose magnesium and calcium. So all of these ones are lost in urine. And there is excessive or frequent urination when these drugs are taken. That is what we can talk about. In the beginning, we had said they have longer duration of action, but actually they have they are short acting. These ones have short duration of action. So this is their mechanism of action. So we find there is constant loss of sodium, chloride, potassium, calcium in urine. So these drugs are majorly indicated in hypertension together with edema or congestive heart failure. So we are seeing that indication. These drugs are indicated in the treatment of chronic hypertension, and sometimes this chronic hypertension, we also apply them in the treatment of malignant hypertension, which we call, this one we call it hypertensive emergency. Then those ones of chronic hypertension, especially accompanied with chronic kidney disease. So if you have patients who have chronic hypertension with chronic kidney failure, we can always apply loop diuretics, and also patients with severe hypertension accompanied with organ failure. We can use furosemide, tosemide, and bumetanide. These are the one. And of course, their ADR, their adverse reaction. One of the adverse reaction is that we are losing much of the sodium, and apart from that, we are losing also potassium. So we can see hypokalemia can come in. Hypokalemia, we can see also decreased levels of calcium, that is hypocalcemia. We can also see hypomagnesemia due to loss of magnesium, and even it can lead to dehydration because we're losing a lot of water. So meaning it is contraindicated in people with dehydration, or either people with hypokalemia. You cannot give the loop diuretics. And at the same time, these loop diuretics, they go to the proximal convoluted tubule and block reabsorption of uric acid. So this one can result into hyperuricemia, which results into gout. So another adverse reaction is gout. So always check for gout, that is inflammation of the big toe of the leg and the joints due to accumulation of uric crystals, which can lead to gout. So these are some of the side effects. And remember, these loop diuretics, they are sulfonamides. So people, they can even have allergic reactions. So they can lead to allergy with the people who react with sulfonamides. They can easily react with loop diuretics. So this is what we can discuss under loop diuretics. So the second class we are going to talk about in this session is thiazides. And the thiazides include those which are thiazides and thiazide-like. And example of the thiazide, let us put them here. We have hydrochlorothiazide, we shall have chlorothiazide, then another example in this class we have dendrofluorothiazide. Then those which are thiazide-like, we have chlorothalidone. Chlorothalidone is one of the example. And another example we have metolazone. So these are the examples of thiazides which we are using under hypertension. So these examples of thiazides, their mechanism of action is that for them, they target the DCT, distal convoluted tubule of the kidney. And within the DCT, there are some transporters. And these transporters, whenever we have in the glomerular filtrate sodium and chloride, the sodium and the chloride, they enable their reabsorption back into blood. So we see these transporters enabling reabsorption of, there is always reabsorption of sodium back into blood in the presence of aldosterone. But what the thiazide do, they come and block the sodium transporters and chloride, because we know sodium moves with the chloride. So when these thiazides block the reabsorption of sodium, so these ones act by blocking sodium transporters. But remember, when it is blocked, we are increasing sodium excretion. Hence, they increase sodium excretion. At the same time, potassium and other cations. So these ones, they increase their excretion in urine. And the more you lose sodium, water follows. So means this one increases urination with a lot of nitrasis, whereby the urine contains much of the sodium. So that is the mechanism of action, by inhibiting reabsorption of sodium in the distal convoluted tubule of the kidney nephron. And their indication, these drugs are indicated, or they are therapeutic use. We are using them. These drugs, they have long duration. These ones have long duration of action. So we can use them in treatment of chronic hypertension. So they are used in treatment of chronic hypertension. They are preferred than rope diuretics because of their long duration of action. So these ones, they are more preferred than the rope diuretics, because rope diuretics have short duration of action, that is between 2 to 4 hours, but these ones, they have longer duration of action. That's why we are indicating them in chronic hypertension. Whereas the rope diuretics, we use them in hypertensive emergencies. That is what we can do. So that is their indication. And of course, another indication apart from chronic hypertension, we can also use them in hypertensive people who have a problem due to increased blood volume. If someone's hypertension is due to increased blood volume, we can give the thiazides so that we can increase loss of water in urine. And also we can also give to the hypertensive patients with edema. So if a patient is hypertensive and they have edema or they have increased blood volume, we can treat them using thiazides, that is hydrochlorothiazide, chlorothiazide, benzofluomethanside, we have chlorthalidone, and so forth, which can be indicated. Their adverse reactions are the same as for rope diuretics, whereby they can cause hypokalemia, hypocalcemia, hypomagnesemia, and also they can lead to gout. So the adverse reactions are the same as the rope diuretics. So this is what we can cover under the thiazides. Then lastly, we have the potassium-sparing diuretics. And these potassium-sparing diuretics, the name itself is saying potassium-sparing. So meaning these guys, for them, they inhibit reabsorption of sodium. They inhibit sodium reabsorption, but at the same time they spare, or they don't tamper with the potassium. So for the potassium can continue to be absorbed. So they inhibit sodium, sparing potassium. That is what its name suggests. So their mechanism of action, as we are going to give examples of the potassium-sparing diuretics include amylolide, and this amylolide, and another example we can have is triametarin. Then the last one is spironolactone. These are the three examples. Why am I separating this is one category and another category? Because their mechanism of action differ. We're going to see that amylolide, these ones, their mechanism of action is they act by inhibiting. For them, they inhibit sodium reabsorption, meaning they also, at the long run, they increase sodium excretion in urine, but sparing the potassium. Remember, they don't tamper with the potassium, so potassium can be reabsorbed. Hence, we don't have a problem of hypocalcemia. Whereas the spironolactone, for it, its mechanism of action is aldosterone blocker. So it blocks aldosterone receptors. This aldosterone is produced from the adrenal cortex, so it acts by blocking aldosterone receptors in the DCT, that is distal convoluted tube. That in the distal convoluted tube we have the principal cells which act as receptors for aldosterone hormone, where it attaches and increases sodium reabsorption. So if you take a drug like spironolactone, it is able to inhibit the binding. So this one in turn inhibits binding. It inhibits the binding of this hormone, preventing sodium reabsorption. So sodium cannot be reabsorbed. And because we are not reabsorbing sodium, we increase its excretion in urine. So it is excreted in urine, but remember it does not tamper with the transporters of potassium. And these drugs, they are indicated for their use. They are being used, their therapeutic use is we are using them in treatment of hypertension together with accompanied with edema, especially in chronic kidney disease. We can also use it in treatment of hypertension secondary to primary hyperaldosteronism. So if there is hypertension due to overproduction of aldosterone hormone, we can use spironolactone in treatment of this secondary hypertension due to primary aldosteronism. But the adverse reaction of these drugs, their ADR, the adverse reaction include, because they are sparing potassium, so we can easily see hypercalcemia, hyperkalemia. The patient can suffer from hyperkalemia, or we can also see gynecomastia. That is the development of breast tissue in male, which can lead to loss of libido and impotence. So if people are on spironolactone amyloride. The end result can either be gynecomastia or hypokalemia, which can also, this gynecomastia can result into loss of libido and impotence, and sometimes ladies suffer with the menstrual disturbances when they are on these drugs. So those are some of the ADR. So these are the indications of potassium-sparing diuretics. And these potassium-sparing diuretics, they are not given alone. They are given in combination with other diuretics, so that when thiazides and loop diuretics, they are causing hypokalemia, these ones are added in so that they can cause hyperkalemia to counterbalance the adverse effect of these other diuretics. So they are not given alone, but they are given in combination. That's what I can tell you this side. And also these two drugs, the loop diuretics and the thiazides, we can use them we normally use them when there is hyperkalemia. If a patient is having hyperkalemia, still we can give either thiazide or loop diuretic so that we can increase loss of potassium. But in case there is hypokalemia, then you give potassium-sparing diuretic. And I have said this one is not given alone. It's given in combination with other loop diuretics. Thank you so much for learning with us at Medical Sciences. Hope you always learn a lot from us at Medical Sciences, and we are always privileged and happy to serve you. Thank you so much.